Welcome back guys. Now in this video let's discuss about the disorders of hemostasis, the primary and secondary hemostasis. Before going into the video, I just want to make a small correction here. Look here guys, in the previous video we have discussed about this vitamin K, right? I have made a small mistake out of confusion. See, this enzyme, this is not vitamin K epoxygenase, this is vitamin K epoxy reductase. See, reduction is happening, right? So vitamin K epoxy reductase, and this enzyme, okay, is not vitamin K reductase, it is gamma glutamyl carboxylase. See, gamma carboxylation is happening, right? So gamma glutamyl carboxylase. Okay, gamma glutamyl carboxylase, please make it a correction. Okay, so gamma glutamyl carboxylase is helping in the gamma carboxylation of 2,7,9,10, and reduction back is done by vitamin K epoxy reductase. So warfarin is going to inhibit the vitamin K epoxy reductase. That's a mistake which happened from my side. Just please make a correction. Now after this, now in this video, let's begin the topic of disorders of primary hemostasis. First we will discuss about the primary hemostasis disorders, later on we will discuss about the secondary hemostasis disorders. So primary hemostasis disorders means problem with what? Problem with platelets. Now what kind of problems, if you ask me? See, there are two types of problems with the platelets. Two types of problems you can have. One is the quantitative problem. One is quantitative problem, means with the number of the platelets, how much platelets are there, how many number of platelets are there, the platelets are going down. So quantitative problem. Second one is qualitative problem, means the quality is affected. Okay, qualitative defects as well as the quantitative defects. So what are these quantitative defects, if you ask me? Quantitative problem here is thrombocytopenia. Okay, thrombocytopenia. The name itself is a thrombocytes. Penia means getting less. Thrombocytes means platelets are getting lesser and lesser. Okay, so how much actual is considered as a thrombocytopenia? How much low is considered as a thrombocytopenia, sir? See, if you have less than 50,000 platelets, okay, if you have less than 50,000 platelets per microliter, okay, per microliter, if you have this much amount of platelets, less than 50,000 platelets, then it should be considered as thrombocytopenia, sir. Okay. Next, what is qualitative problem? Qualitative problem is the quality of the platelets is affected, means defective platelets. Okay, defective platelets. So now, one is a number problem, other is the quality problem. One is a number problem and other is a quality problem. So now let's begin our topic with the quantitative problems. Okay, quantitative defects. Okay. Now under quantitative defect, the first disorder that I am going to discuss here is called as immune thrombocytopenic purpura. Okay, immune thrombocytopenic purpura. So what exactly is this immune thrombocytopenic purpura? In the name itself, it's very clear, immune system. Okay, it's the immune system which is causing the problem. It's an autoimmune condition, first of all, autoimmune. So what is happening? Thrombocytopenia is there, which is leading to purpura. Okay, immune system is the one which is causing the thrombocytopenia, and that thrombocytopenia is causing the purpura. So what exactly is purpura, sir? Purpura is nothing but the bleeding. Okay, visible bleeding in the skin. Okay, if you have small dots of bleeding, okay, small dots of bleeding, okay, pinpoint sized hemorrhages, then they are called as PTK. Okay, PTK are small pinhead sized bleedings. If there is a little bit more bleeding, okay, the area of the bleeding is little bit big patches are there, then it is called as a purpura. If you are having more bigger patches, of bleeding. You can see a more bigger patches of the bleeding, then it is called as the ecchymosis. So petechiae, purpura and ecchymosis, all these are nothing but the bleeding. Okay, so the bleeding is happening because of platelet deficiency. Platelets are not there, that is causing the bleeding. So platelet deficiency is going to cause the bleeding. That's the problem, right? Because of what? Immune system. So what exactly is the problem, sir? Here is, so it's the spleen. The culprit here is the spleen. Okay, in the spleen also splenic plasma cells. So these plasma cells unnecessarily they are producing IgG type of antibodies, some IgG antibodies. Against what? Against the platelets. Now see, imagine this is a platelet. Now these IgG antibodies are coming and they are coating the platelet like this. Now this antibody coated platelets, okay, these antibody coated platelets are consumed by the splenic macrophages. When these platelets, whenever they are going through the spleen, okay, here is the spleen. Now in the spleen, the splenic macrophages, these splenic macrophages are going to take up this platelets which are coated with IgG antibodies and the platelets are totally destroyed. So thrombolysis, the platelets are getting destroyed, sir. So that's what causing the thrombocytopenia. So who is the main culprit in our story? The main culprit in our story is it's all the spleen. So splenic plasma cells are producing the antibodies and splenic macrophages are continuously destroying the platelets. So which is leading to thrombocytopenia, and that thrombocytopenia is causing the purpura. Okay, purpura means bleeding into the skin. Without platelets, of course the patient will bleed. So such type of autoimmune disorders, okay, of course this is a mild condition, it's not a severe condition, it usually self-resolves after some time. So this immune thrombocytopenic purpura, which is also called as a simple form ITP, okay, ITP, it is seen in causes, seen in females of childbearing age. Okay, it is seen in children of childbearing age. Also seen in children after viral infection. Are seen as secondary to other autoimmune disorders like SLE. Okay, so if a patient is having SLE, these patients can also develop the immune thrombocytopenic purpura, sir. So seen in females, all the autoimmune disorders are more commonly seen in the females, and children after the viral infection or SLE or rheumatoid arthritis, some other autoimmune associations are also there for the immune thrombocytopenic purpura. Now what you will see in the labs, sir. Okay, the patient who is having ITP, what are their labs? Okay, how the labs are going to be? Look. Number one, what about their platelets? Platelet count is getting decreased. So first, thrombocytopenia. Okay, there is destruction to thrombocytopenia. So how much, sir? Less than 50k platelets, 50k per microliter, less than 50k platelets per microliter, sir. Okay. Next, what else? Thrombocytopenia. Next, it is bleeding time. So bleeding time is totally dependent on the platelet plug formation. If platelets are good in quantity, if it completely forms the platelet plug, that is the platelet adhesion, platelet aggregation is completed. So within just 2 to 7 minutes, okay, within a range of 2 to 7 minutes, bleeding will stop, sir, usually. There is no need of clotting factors. I am not talking about the clotting factors. I am only talking about the platelet plug formation. That's the primary hemostasis. Bleeding time depends on the primary hemostasis. Okay. Now here bleeding time increases. Why bleeding time increases? Because platelets are going down. What about the PT and PTT? PT levels and PTT are going to be normal. Okay, PT and PTT are going to be normal because clotting factors are not affected. PT and PTT are normal. So thrombocytopenia is seen, bleeding time is going to be increased, PT and PTT levels are normal. Now, for these patients, what is the treatment that we are going to give? The treatments. So you know the clinical features, okay, deep, the mucosal bleeding is going to occur, the patient whenever he is having a wound for much time, the bleeding is going to occur, okay. So treatment is, in this patient the culprit is the spleen is producing the antibodies and spleen is consuming the platelets. So we have to remove the splenectomy. Okay, we have to remove the spleen, so splenectomy is done for immune thrombocytopenic purpura, and also we have discussed in the hematology, okay, in the RBC disorders also we have discussed that splenectomy is also done for hereditary spherocytosis. Splenectomy can be done. Now for these patients you can also give transfusions, okay, platelet transfusions. So now one quantitative defect is completed. One quantitative defect, that is immune thrombocytopenic purpura. The second quantitative defect that I am going to discuss now is called as microangiopathic hemolytic anemia. Okay, so microangiopathic hemolytic anemia. So what exactly is this, sir? So it's also simply called as MAHA. Okay, microangiopathic hemolytic anemia. So in the name itself it's there. Microangiopathic means there is some problem within the smaller blood vessels. Okay, right? Problem in small blood vessels. There is hemolysis. Okay, so because of this problem there is hemolysis, that is RBC destruction, and that's what is causing the anemia, sir. Okay, so there is problem in the microangiopathic hemolytic anemia. Okay, so now why microangiopathy, why hemolysis is happening? Okay, we'll discuss one by one and how this is related to our platelets. Okay, we are discussing about the platelets, right? But then why it came microangiopathic hemolytic anemia? We'll discuss under microangiopathic hemolytic anemia. The two causes of microangiopathic hemolytic anemia are, first cause is TTP, thrombotic thrombocytopenic purpura. Okay, thrombotic thrombocytopenic purpura, which is also called as TTP. So what is the problem in thrombotic thrombocytopenic purpura? See, here there is a deficiency, in this condition there is a deficiency of an enzyme, okay, deficiency of an enzyme called as ADAM TS13. So deficiency of ADAM's TS13. See, this ADAM TS13s, it actually cleaves, okay, it breaks down von Willebrand's factor. Once the function of the von Willebrand factor, platelet adhesion, platelet aggregation, wound healing completed, now this ADAM TS13, it cleaves the von Willebrand factor and clears the von Willebrand factor. Okay, your function is done, now your function is no longer needed. But if you are having deficiency of this enzyme ADAM TS13, then von Willebrand factor is now continuously activated. What von Willebrand factor will do? It helps in platelet adhesion followed by platelet aggregation, so leading to thrombosis. Platelet aggregation means more and more platelet aggregation is happening. If more and more platelet adhesion, more and more platelet aggregation is happening, what happened to the amount of platelets? Unnecessarily useless. Okay, unnecessarily the platelets are being used up because of the deficiency of this enzyme, because the von Willebrand factor is continuously getting activated. Okay, unnecessarily now this platelet aggregation is happening. Now because of this, what happens, sir? Look, within the blood vessel unnecessarily the platelets are binding with one another because of this von Willebrand factor, and within the blood vessel what you can see is this small platelet microthrombi. Okay, these are all the platelet, these are all the platelet clots. Okay, this is just like hills within the blood vessel, small hilly areas. Now when such abnormal microthrombi are present, see, these are all the platelet microthrombi. Now these platelet microthrombi are getting over there unnecessarily. So when the blood cells, okay, especially the RBCs, not only RBCs, WBCs also, when the RBCs, whenever they are going through the blood, okay, such smaller blood vessels which are having smaller lumen. So RBCs are going to hit, okay, RBCs are going to hit to such platelet microthrombi and they are going to be sheared, leading to hemolysis, intravascular hemolysis. Now the RBCs are going to cause, like, there is damage to the RBC cell membrane. So what kind of RBCs you are going to have? You are going to have damaged RBCs. So these damaged RBCs are going to look like helmet cells. Okay, they are going to look like helmets, so they are called as the helmet cells, which are also called as cystocytes. They are called as what? They are called as the cystocytes. So cystocytes are damaged RBCs, are helmet cells. Now why cystocytes? Because of the platelet microthrombi. Why platelet microthrombi? Because of the von Willebrand factor activation. Why von Willebrand factor overactivation? Because of the deficiency of iron 13. Okay, so the name thrombotic. Why thrombotic? Here see, these are the thrombi. Okay, leading to thrombocytopenia. Why thrombocytopenia? Because of the platelet overusage. See, there is consumption of the platelets. All the platelets are being unnecessarily consumed. So thrombocytopenia leading to purpura. Thrombotic thrombocytopenic purpura will lead to microangiopathic hemolytic anemia. Okay, why microangiopathy? In thrombotic thrombocytopenic purpura, you can very clearly see there is a microangiopathy. Platelet microthrombi are present in the smaller blood vessels, which is going to cause the RBC destruction. Okay, next, sir, in thrombotic thrombocytopenic purpura, what are the labs? Labs, you know it. Okay, platelets are getting unnecessarily consumed, so platelet levels goes down, bleeding time increases. But here you will see this such thrombi, platelet microthrombi are going to especially involves okay, nervous system. Okay, involves the nervous system. So these patients are going to have the neurological symptoms. Okay, these patients are going to have the neurological symptoms. The reason why I am telling you this is because to differentiate with some other condition which is called as hemolytic uremic syndrome. Okay, the second disorder which is going to cause, see, the first disorder which is going to cause the microangiopathic hemolytic anemia is thrombotic thrombocytopenic purpura. Now the second disorder that is going to cause the microangiopathic hemolytic anemia is hemolytic uremic syndrome. So what is happening in the HUSR, hemolytic uremic syndrome, is, see, this is because of an infection. Okay, there are even other causes also because of an infection. So infection with what? Infection with an organism called as E. coli O157H7. Okay, this organism E. coli O157H7, what this organism is doing, sir? This organism is going to produce a toxin. If you get infection with this organism, it's going to produce a toxin called as verotoxin, E. coli verotoxin, which is also called as Shiga like toxin. Okay, E. coli verotoxin or Shiga like toxin. So at the end of the day, what this verotoxin is going to do? It's going to cause an endothelial damage. So you know it, once the endothelial damage occurs, once the endothelium is damaged, automatically the microthrombi will form. Okay, so in multiple places, especially involving the renal vasculature, okay, especially in the renal vasculature, the endothelial cells are getting damaged. The endothelial cells are getting damaged. Because of the damage to these endothelial cells, on the endothelial cells, now platelet microthrombi are getting formed. Okay, all this, see, these are the platelet microthrombi because of the damage to the endothelial cells because of the toxin. Now you know it from here, the story. So these platelet microthrombi are going to cause the hemolytic anemia, microangiopathic hemolytic anemia. But the question is, which involvement is there? Mainly kidney involvement. Kidney involvement. So the patients are going to have the kidney related symptoms. Okay, in thrombotic thrombocytopenic purpura, the patient is going to have the neurological symptoms. Here the patient is going to have the kidney related symptoms. Okay, so this is how to differentiate between TTP as well as hemolytic uremic syndrome. So at the end of the day, even in this condition also, see, in the hemolytic uremic syndrome, unnecessarily there is formation of the platelet microthrombi. Okay, platelet microthrombi are forming. So because of that, what happened to the platelet count? Platelet count is going to go down. So quantitative problem. When the platelet count is going down, okay, what happened to the bleeding time? Bleeding time increases. What happened to the PT-PTT levels? PT and PTT. PT-PTT levels are going to be normal. Okay, so in the name itself it says hemolytic uremic syndrome. Uremia means kidney related problem. There is accumulation of the nitrogenous waste products in the body, that is a uremia. Okay, first usually there is azotemia, there will be uremia, right, because of the kidney failure. So the patient is going to have the kidney failure symptoms like uremia. So with this the quantitative problems are completed. Okay, the quantitative problems, that is two important problems I have discussed. Immune thrombocytopenic purpura completed. Also we have discussed about the microangiopathic hemolytic anemias, the two causes of the microangiopathic hemolytic anemias. One is thrombotic thrombocytopenic purpura and the second one is hemolytic uremic syndrome. Quantitative defects are completed. Now let us discuss about the qualitative defects. Means the quality related issues. Qualitative defects. Sir, what are the qualitative defects? See, I have said you GP1B. Sir, GP1B is involved in what? GP1B is involved in platelet adhesion. GP2B3A. Okay, GP2B3A is involved in platelet aggregation. See, there are certain disorders in which this GP2B and GP2B3A are defective. They are not there. So GP1B absence is going to cause defect in platelet adhesion. This syndrome is called as Bernard-Soulier syndrome. Okay, Bernard-Soulier syndrome. So what is the problem in Bernard-Soulier syndrome? Platelet adhesion or aggregation defect? Platelet adhesion defect. Problem is with which molecule? GP1B molecule. In other condition which is called as Glanzmann thrombasthenia. In this Glanzmann's thrombasthenia, the problem is with GP2B3A. So platelet aggregation defect. So in both the conditions, platelets are not undergoing platelet adhesion and platelet aggregation. Because of that, what happens? Disorder of primary hemostasis. Again, qualitative problem. So what happened to bleeding time? Bleeding time increases. So the patients are going to lose more and more blood. Okay, so bleeding time increases. Okay, so that will cause more and more bleeding. So with this, the disorders of primary hemostasis are completed. In the next video, we will discuss about the disorders of secondary hemostasis. That's the clotting related problems. Okay guys, thank you.